Okay, so this lecture is about integumentary assessment and care. This is going to be the basics. It will be a review for some of you. There may be a little bit of new information for others, but we're talking about basic skin care. In first, we're going to talk about assessment. This first section will be the health history and the inspection and palpation part of assessment. So when we're taking a health history, the things that we need to be aware of in regards to skin health or integumentary care is, first of all, their skin risk assessment. The Braden scale is an assessment tool that we use to evaluate the risk for pressure ulcers. Every patient being admitted into an inpatient setting should have a Braden scale done. There are guidelines for how frequently those should be redone. In long-term care, there's very specific guidelines, because when we look at that risk, it gives us some ideas of what interventions we'll need to do to prevent that from happening. We also want to ask our patient, have they had recent changes in skin color? If so, what kind of changes and where are those located? For example, my toe turned black or my lips turn blue when I have a coughing fit. We want to know those kind of things. Do they have any rashes? If so, where? What do they look like? What do they feel like? Are they itchy? How long have they had them? What have they done to try to help those things? Do they have any new moles or any new lesions? New moles or changing moles can be a sign of skin cancer. So we want to teach patients to be aware of any marks they have on their body and if those begin to change. And then if they have any new lesions or wounds of any kind, what do those look like? How long have they been there? What have they done to try to treat those things? We want to assess sun exposure and protection. Are you in the sun frequently? And are you using sunscreen? We want to ask about edema or swelling. If they have swelling, where is it? Is it painful? What makes it better? What makes it worse? Does it happen at a specific time of day? Because that can help us determine the likely cause of that. So that's the health history piece. Frequently in the health history, we hear things that make us want to investigate further. So I always want you to be aware of, this patient says, well, my toe's black. I should probably look at that toe and see what's going on. How long has this been happening? Did you have an injury? Is there a hematoma under the toenail, or is that toe necrotic or ischemic? So we want to make sure that we're following up on those cues. Inspection and palpation. When we look at skin, we need good lighting. We need to have the room temperature comfortable enough that we can expose the skin that we're looking at. We need to provide privacy for that exposed skin. And we need to expose all of the skin, uncovering one body part at a time and maintaining privacy and comfort for that patient. We want to compare the skin for symmetry from one side of the body to the other. Put gloves on to touch any lesions, and we need to measure lesions. Okay. When we're inspecting and palpating hair, skin, and nails, we want to look, is the skin color what we expect for ethnicity? Do we see pallor? Pallor can mean things like anemia or shock. Do we see cyanosis? Cyanosis can mean hypoxia. That's bluish if they look blue. Jaundice is a yellowish undertone to the skin caused by bilirubin. And if you're unsure if your patient has jaundice, check the sclera and palms. That makes it easier to see. Erythema is redness. There are things that can cause redness of the skin. So we need to look for that. Brownish pigmentation changes on the lower extremities. So if there are brown splotchy patches on the lower extremities, on the calves especially, that's often an indicator of venous insufficiency. So I would want to ask that patient, do you have varicose veins? Do your feet swell? Because that's usually a sign of chronic venous insufficiency. If the lower extremities have skin that is shiny, kind of translucent, and hairless, that can be a sign of arterial insufficiency. That skin begins to atrophy because of poor circulation. So I would want to ask about things like, do your legs hurt when you're up and walking? Age spots are called senile lentigines, and they are connected to sun exposure as well. When we're inspecting skin, one thing that you should know is that most of our images we see, to compare to most of the images in our textbooks, are based on on white skin. So people with dark skin, some of those lesions, some of those rashes, some of those indicators may look different. There actually was a med student who published a book of photos of different skin conditions on Black skin in particular. I would like to see that expanded, because sometimes we miss things because they look different because of different skin color. So be aware that what you see may look a little bit different. Temperature. Skin hopefully is warm and dry depending on the ambient temperature. If it's 40 degrees outside and I walk in, if my skin is warm and dry, I may have a fever. But typically in a comfortable room temperature environment, skin should feel warm and dry. If it's cool, that may indicate vasoconstriction or poor circulation. So be aware of, we want to be aware of temperature. And the consistency of the skin should be smooth, soft, and even. If lesions are there, can you palpate them? If there's a red spot, do you feel anything? Is there a crust? Is there a bump? We also want to check for skin turgor. Where do you check for skin turgor, especially on someone who's older? A lot of us are used to checking skin turgor on the back of the hand. When people age, that skin on their hands tends to age faster, it tends to get looser earlier. And so we may have someone who's very well hydrated and their skin is tinting on the hand just because of aging. So check skin turgor over the sternum. Check the skin over the sternum for skin turgor. Hygiene, is that patient clean and well groomed? That can be an indicator of general health or of potentially mental health concerns, or of mobility concerns. So if someone appears to not be clean or well groomed, we want to evaluate why that is. Nails, we want to see pink symmetric nail beds. There are some specific things that happen to nail beds that are connected to different disease processes, and we're going to talk about that. Let's see if those are in here. I actually don't see those in there, so I want to talk a little bit. If patients have psoriasis or severe skin rashes on the hand, they may have pitting in the nails. If someone's had a serious illness, they may have a line across the nail where it appears that the nail is just thinner. Those are called Bowes lines. And then over time that grows out. Severe anemia can cause spoon nails, where the ends of the nail seem to kind of grow outward. And chronic hypoxia can cause nail clubbing. If you look at the nail beds, there should be a very slight concave angle where the nail bed meets the finger. With chronic hypoxia, that angle begins to change. You'll see it flatten out, and you can even see it become convex. So pay attention to those things. Oh, I see it here actually. Pitting, Bowes lines, spoon nails. Decreased circulation also causes nails to thicken. And if we have psoriasis, can cause nails to become yellowed, but also fungal infections can cause nails to become yellow, thick, and crumbly. And that's most likely to happen in toenails, but it can occur in fingernails. With trauma to a finger, we might see splinter hemorrhages, but we also might see those splinter hemorrhages with endocarditis. Nail beds also, we may see pallor or cyanosis, and we look at cap refill. We want cap refill to be less than 3 seconds. If it's more than 3 seconds, that's an indicator of poor perfusion. Hair, we look for even distribution. If that patient has hair loss, is that hair loss symmetric? Okay, so I am going to stop there. We're going to come back and talk about edema and about identifying different types of lesions on the skin.